Kelly.รู้แหละใช่ครับ
Hi, everyone. Thank you for joining. We will give everyone just a few minutes before we get started, and then we will kick off with our webinar. Thank you again. Okay, great. Thank you all for joining. My name is Miriam Khan. I am the Communications Director at Gradient Health Systems based here in New York. I just wanted to take a few minutes to welcome you to this webinar and thank you for joining, and then also just go through a couple just housekeeping tips to get started, and then I will turn it over to our moderator, Dr. Indaba, to get us started. If you have any questions during this webinar, you can use the Q&A function on the either bottom or top of your screen to ask questions. We'll have time at the end to answer either live or via the chat feature. This webinar, as you can see, is being recorded. There will be a copy sent to you in your email after the webinar. You can also access it on our website, gradienthealth.org, under our training page or on our YouTube page as well. And again, if you have any questions, feedback, any ideas for topics you'd like to see covered in our webinars coming up this year, feel free to email us at customers@gradienthealth.org. Now I will turn it over to Dr. Ndaba to introduce the session and to introduce our panelists as well.
Thank you very much, Mariam. Kindly confirm once again that I'm audible.
Yes, perfect.
Thank you. Yeah, thank you so much for that. And I would like to warmly welcome all the colleagues, senior colleagues, colleagues in training, and all the providers that have found time to actually join this very important webinar. So today we have a very interesting discussion. We want to explore the roles of the anesthetist beyond the operating theater. So we are basically discussing the role or the unique position that the anesthetist occupies in the healthcare system, zooming into the specific areas of operation beyond the operating theater. I think that's a very, very important discussion that we have today. So to help us run through the session, we have two very qualified and well-able physician anesthetists that are going to take us through the presentation. The first one is Professor Abdullahi Mohammed. Professor Abdullahi is based in Nigeria. He is the associate professor based at the Bayero University in Kano State. And also he is a consultant physician anesthetist for Aminu Kano Teaching Hospital in Kano State, Nigeria. So he brings with him a wealth of knowledge, of practice, as well as experience that he would like to share with us as far as this topic is concerned. Then we have Dr. Katongo Mumba, who is going to be our second presenter to run us through this session. Dr. Katongo, he's a fellow of the pediatric anesthesia based at the University Teaching Hospital in Lusaka, Zambia. He also brings in expertise in the field of anesthesia, as well as experience from the years of practice that he's had so far. So to moderate this session, my name is Dr. Ndaba Spuka. I'm also a physician anesthetist who is based in Lusaka, Zambia. I'll be the chair for this particular session. We also have our two panelists that are going to help us discuss this session later on. So we have Dr. Papichon Tambwe, who is a physician anesthetist. I think most of you have heard or have known him. So he's a physician anesthetist from Livingstone, Zambia. And then we also have Dr. Sweetbet Ansbet Ndebeya, who is also a physician anesthetist from Tanzania. So without much ado, let me just go through some of the objectives that we will run through. So we are going to explore the roles of the anesthetist outside the operating theater, focusing on some of the potential areas that the anesthetists may find themselves useful. We will discuss some of the competencies that the anesthetist has that actually may give them that special role within the healthcare system. So we'll also run through the role the anesthetist has in the multidisciplinary team setup, and then we'll examine some of the educational responsibilities as well as capacity building roles that they are anesthetists with a wealthy of competences that may engage. Then we'll end with some of the recommendations that we think can be helpful as we strive to contribute to the healthcare system as a whole in a positive manner. With that introduction, I would like to introduce the first speaker, who is Professor Abdullahi, to run us through the first part of the presentation. Thank you so much. I now invite you, Prof.
Thank you, Dr. Ndaba, for the presentation, for the introduction. Thank you, Dr. Miriam Khan, for the first introduction and the panelists. My name is Abdullahi Mustafa Miko. I'm a consultant anesthetist. I'm from Kano, Nigeria. So please, can we have the next slide? So by way of introduction, we are going to talk about anesthesia, which is a dynamic process which has been evolving into so many subspecialties. So anesthesia is a dynamic and evolving specialty. We are used to be known to be in the operating theater traditionally, but nowadays this traditionally centered in the operating room. We are now more into other places that we work outside the operating theater. The seat across, so it's where we also get some of these things done outside the operating theater. Our roles now is on the perioperative assessment of patients, where we see the patient before, during, and after surgery. And then we also take part in the critical care of patients, including pediatrics, emergency cases, where we see patients in the emergency room, and then the preventive care. Next slide, please. So this, our role outside the operating theater. Where do we work, and what is our contribution beyond the surgical anesthesia? As I have started saying, we are in the acute pain management, where anesthetists form part of acute pain management, such as the ones that we see later, like in labor. We can be part of acute pain management, post-operative pain management, or in chronic pain management, like in the palliative care, and then in the critical care of a patient. And again, our expertise give us the upper hand to provide leadership in emergencies and life-saving intervention, such as airway intervention, such as life support intervention, like the basic life support or advanced life support. Next slide, please. So we have the pre-operative assessment clinic, where we see the patient, give comprehensive evaluation. We look at the patient, take our history, have a rapport with the patient at the preoperative visit, examine the patient, and give our own assessment. By the time we assess the patient, then we now look at the possibility of optimizing the patient if the patient has an unoptimized comorbidities, like the patient is still having hypertension. We and the surgeons, we can now decide on how to treat that hypertension, diabetes, and asthma that we are having as the comorbidities that can come at any time for any surgery. Having done that, we now look at the risk stratification and then the preoperative planning, how we are going to do, which type of anesthesia we are going to do this patient, and we look at the informed consent so that the patient will have the best type of anesthesia. This, when we do it in combination with the surgeon, it reduces the cancellation of surgeries. So when you bring out an optimized patient that you have already planned for him, it's unlikely the case is going to be cancelled. And this will also reduce the complication that can happen during and after surgery. Next slide, please. So we also need to talk about the post-anesthesia care unit. This is a specialized area in the theater or where we monitor patients just after the anesthesia. And in this place, we continue monitoring the vital signs of the patient, looking at the airway so that they don't become compromised. We look at the blood pressure, the hemodynamics, continue giving IV fluid, continue monitoring for pain, and then we can continue with our pain management also in the post-anesthesia care unit. In the post-anesthesia care unit, we prevent if a complication, if they are going to arise, early detection, prevention and early detection of complication. If we see, we can act immediately. Next slide, please. In the intensive care unit, is a non-pack that we provide care, and we are part of the leadership of the intensive care unit, where we see critical care patients that might need mechanical ventilation to support their respiratory system, and then hemodynamic monitoring, whether invasive or non-invasive. We see the blood pressure, we see the arterial blood pressure, central venous pressure, to monitor the organs of the patient and continue to support in the multi-organ compromise. And then patients will get better with this strategy. Next slide, please. Can we have the next slide? Okay, thank you very much. And in the emergency department, where you can patients that can come into the emergency department, like trauma patients, where they can have a compromised airway, we provide the airway management. When we have patients that are having medical emergencies, such patients like those in the DKA, we participate in the management. If needed, we continue with our fluid resuscitation of patient that comes into the emergency room. If there is a need in securing the airway, we can do a rapid sequence intubation at that time, and then we put down our endotracheal tube or endotracheal tube below the vocal cord, and put some source of oxygen to enrich the resuscitation and stabilization is done within the emergency room, and then the patient will be the appropriate word in the sorry, I just got I'm sorry, I just got off the line. So thank you. Please, next slide, please. Pain management in the clinic. In the pain management, as we started discussing, acute pain management is part of the pain that we manage using the multimodal pain management, giving opiates, strong opiates, anti-inflammatory drugs, and even blocks can be use in the treatment of acute pain management, and combination of different drugs with different mechanism of action can be used. And chronic pain management, which is a multidisciplinary pain management. We are part of palliative care. We get our involvement together with the nurses and the pharmacists and the physiotherapists in the management of chronic pain and even palliative care. Regional blocks are now giving us a good, excellent pain management. This includes the epidural, this our epidural, erectospinal block, paravertebral block, etc. These are the blocks that are being used to give good acute postoperative pain management and interventional pain management for those patients with chronic pain, such as knee pain, where you can do some Next slide, please. Next slide, please. Hello?
Yeah, we can hear you, Prof.
Palliative care.
Hello, Prof. Are you there?
I think he may have lost his connection.
Yeah.
In the palliative care, the symptom control in terminal illness, where you have patients that are having terminal illness, you need to provide them with a good pain management, comfort them so that you reduce their suffering. When they have dyspnea, you manage the dyspnea, and then so that you improve their quality of life, they can enjoy themselves before the end of life. Thank you. Next slide, please. In the obstetric unit, we also have a role to play, not only during C-section. When there is labor, we can now have pain relief during labor, where we can give epidurals, or we can do the Lames maneuver, continue with our some acupuncture we can do. And in the obstetric emergency, when we need to have a holistic view of the patient so as to now prepare for any unforeseen circumstances that can happen during this emergency. And emergency cesarean sections, like you can have retained placenta or retained product which can be removed under anesthesia. So all these obstetric emergencies, we need to prepare, get involved other disciplines that may take important role, such as the blood bank. If you have obstetric hemorrhage, you can involve them, and then involve the neonatologists to get the patient resuscitated. So we play a role both in the obstetric emergency, if there is going to be a surgery, and then the relief of labor. Thank you very much. Though epidural is the mainstay now, it can give you an excellent pain relief. And then apart from epidural, you can also use your IV medications, opioids, IM. Thank you very much. Next slide. And again, we provide our services in remote areas when they are going to do some radiological investigations, more especially in the extreme age group, where patients cannot be asked to stay in one place, and we need to sedate them, give them some sedation so that they can do this radiological investigation, such as magnetic resonance imaging or CT procedures. And again, for the radiologists that are given some intervention, maybe you are going to do somebody with pulmonary emboli and they want to go and dissolve it using the radiological imaging, and then you can now go there and assist them with sedation, and so that they can do. Even in the non-operating room, we must ensure safety of this patient. We have to get some of our oxygen source, our monitoring device, at least the standard monitoring, so that we can continue monitoring the patient to ensure safe anesthesia that is given during this intervention. Next slide, please. Next slide, please. So anesthesia outside the hospital setting, a contemporary issue. These are review of anesthesia and analgesia in the field with emphasis on airborne military operations. It has been postulated that it has been proven that more than 40% of patients that will have survived during casualty or during accident that are severely wounded will die before reaching the hospital. They could have survived otherwise if they have timely intervention. So this possibility of incorporating lightweight modem of equipment in the field of anesthesia are also brought out so as to help these patients. Next slide, please. So anesthetist has to get these competent skills because he is an airway manager with expert who is an expert in the management of airway. So he teaches other people how to manage the airway, whether basic airway management or advanced airway management. And then the anesthetists also have some advanced cardiovascular physiology knowledge and pharmacology. And we are together with I'm sorry, please. Together with our critical care decision making under pressure, we can take decision. That we are trained to do that because every day we are in the critical condition in anesthesia inside the operating room. So our decision making is always critical under pressure. Thank you. Next slide, please. So clinical decision making, we have the ability to do rapid assessment to assess a patient and then immediately start intervention so as to identify those patients that are unstable and start their management. Based on that, we can have the evidence of this evidence-based perioperative planning so that we can have our patient that will get the best out of our expertise so they can be safely managed pre, intra, and post-operatively. Thank you very much. Please, can you give me next slide? Next slide, please. Hello?
Hi, just confirming that you can see the next slide.
Hello, Prof. Are you there? We can't hear you anymore. Are you able to hear us?
I am back. Thank you very much.
Okay.
And also,
all right,
we are good as a resuscitation expert. as we have advanced life support training, and many anesthetists are trainers, AHA, or in their local domain, they can have their resuscitation council, and we are good in doing pediatric advanced life support, advanced cardiac life support, basic life support, and even in trauma, we have advanced life traumas resuscitation with many anesthetists as instructors in all these fields, where we take part in the resuscitation of patients, stabilizing them, and then giving them a definitive care. Thank you. Can you give me the next slide, please? Next slide, please. Thank you. Other skills that are now in the front line is the use of focus, the point of care ultrasound to do some investigation. Now, some anesthetists can use ultrasound in trauma patient to do EFAST, extended focus assessment for a trauma patient. And then you can use it also to guide you in vascular access. You can use the ultrasound for regional anesthesia to do block, which now increase your accuracy and reduce the dose and complications of this regional block if you use these ultrasound skills, which are being used now. In the preoperative medicine, what we do, we optimize patients before surgery by thereby reducing the risk that the patient is posed to. And when you reduce the risks, and then you now reduce the complication that the patient will have post-operatively, and then you now have a good outcome for the patient, and the patient will be safely anesthetized and then has his own surgery. Next slide, please. Next slide, please. Thank you very much. Also, in healthcare system, we have some role to play as leaders of part of the operating team. Operating, this will help in making the theater efficient by involving part of the team that include the anesthetist. And then we have the resource allocation in the system, and then we are part of those that form the protocol of using in the hospital, be it in the ICU, in the theater, or in other places where our expertise is being used. Thank you. Next slide. Thank you very much for your time. Thank you.
Right. Thank you so much, Prof. Was actually nice listening to you. Thank you so much for the information. At this point, I'd now like to invite our next speaker, who is Dr. Katongo Mumba, physician anesthetist from Zambia. Dr. Katongo, if you can hear me, proceed.
Okay, thank you so much, Dr. Sipuka. You can proceed to the next slide. So as mentioned, for the modern anesthetist, we are going beyond just the operating room. So we find ourselves in intensive care units, emergency room, pain clinics, as mentioned by the prof, as well as seeing the patient in the pre-operative clinic for assessment, as well as the optimization, and also in high dependency units. So for intensive care units, this is more of a natural extension of our operating room. So most of our skills are utilized in ICU, mainly for patients who've got depleted physiological reserves, and we are optimizing as well as managing these patients with different comorbidities. So we tend to do a lot of not only procedures, but also resuscitation and destabilization. Equally, in the emergency rooms where we help manage um, patients for trauma, being the airway experts, as well as also managing other systems to have good outcomes. We can go to the next slide. So in high dependency units, this is more of a bridge between the ward and ICU. So we tend to have patients who are in between, and for this we provide intermediate care for unstable patients. So these are patients who, for example, might need maybe care, for example, like cardiovascular support, patients who are in shock, and we need to optimize and pull them out of shock, as well as make sure that they have good cardiac output and perfusion. And as an anesthetist, we find ourselves in this situation, managing these patients, trying to prevent and make sure that these patients don't go through a downward spiral and go into ICU admissions. So we're basically in this role managing these patients and preventing them from deteriorating and becoming worse and leading to ICU admissions. Next slide. So cardiac care units are also units that the anesthetist plays a key role, mainly for hemodynamic monitoring, as we are able to interpret dynamic data from arterial waveforms, central venous pressure waveforms, as well as the use of POCUS in assessing fluid responsiveness and also cardiac contractility and also cardiac output. For cardiac arrest patients, usually post-cardiac arrest patients, we find ourselves in situations where we implement strategies like therapeutic hypothermia to make sure that we prevent secondary brain injury. And as we have exposure to this, the anesthetist is more in touch with pharmacological knowledge to actually choose the right drug for inotropic support, looking at what the patient has in terms of what pathology the patient has, whether it's a cardiogenic shock or distributive shock, what would be the best therapy to actually manage this patient and make sure that we have good cardiac outputs as well as perfusion. In trauma units, as it has been said, we are the airway experts. Patients who come in, for example, with maxillofacial traumas, patients who come in post burns, we are the people who are going to swiftly and carefully manage the airway, making sure that we take all of the cervical spine precautions. In a situation where we are not able to secure the airway, we are knowledgeable about front of neck access and making sure that we're able to oxygenate the patient. We are also well versed in hemodynamic resuscitation, and also we have the knowledge of, for example, permissive hypotension, where when a patient comes in and they are actively bleeding, we implement permissive hypotension to make sure that the clots don't dislodge, as we allow the patient to go in for surgery and have good outcomes. Massive transfusion protocols This is something that is actually seen even in the trauma units where we use point of care coagulation to actually have real time of what is happening in the patient and make sure that we actually give the right blood products, balanced products, so that we stop all of these bleeding. As well as we are aware of pathologies or issues like the lethal triad of trauma, where we have coagulopathy, hypothermia, and all of these things. So next slide. We are also called to the burns unit, where we actively help with fluid resuscitation guidance. As we've mentioned, we are also in a situation where we can actually assess for fluid responsiveness and things like that. So for pain control strategies, besides just having the knowledge and implementing multimodal pain strategies, we are also able to do regional blocks, which will actually help most of our patients. For burns unit, most of the times we are called on to do some procedural sedation, mainly, for example, in situations where we are doing dressing changes. Some light sedation actually helps with patients under the burns unit, which we are actually called for, whether it's going to be bedside or actually doing that in theater. Endoscopy suits actually a place where we do a lot of sedation, whether it's pediatric patients or adult patients, to actually facilitate most of these procedures. For example, under gastrointestinal unit team gets in touch with us. So we are finding ourselves in different situations all around the hospital. And being able to sedate, we are actually able to take all of the safety precautions in most of these places and make sure that we facilitate the procedures being done, as well as make sure that no harm comes to the patient. Next slide. So as an anesthetist, we have seen that we tend to be involved with multidisciplinary teams. We collaborate with specialties all across, from the ICU, collaborating with primary physicians, to collaborating with surgeons, and also collaborating with nurses to make sure that all of our patients are doing well in the PACU as well as the ICU. So we tend to improve outcomes through teamwork. Next slide. So we collaborate with surgeons in a number of different ways. So first of all, perioperative planning, we make sure that we pre-assess our patients. We make sure that our patients are well optimized for the proposed surgery. If there are any recommendations or anything that we can do to actually make sure we have a better outcome, we always recommend that to the surgeons, and we work together to make sure that we have good outcomes. And in a situation where we have, for example, like in the operating room, where it's a dynamic environment, things are always changing there. We have a surgery that's going on, and probably maybe our patient has bled more than we anticipated. We make a shared decisions with the surgeons. We say, okay, looking at what has happened now, or maybe the complications that have happened intraoperatively, what is the decision in terms of where will this patient go? Is it where is the safest place for this patient to be nursed? Is it going to be the HDU? Is it going to be ICU? Such things. So we tend to have shared decision making with surgeons. For enhanced recovery after surgery, for anesthesia, we are the key drivers for ERAS. We our decisions to what analgesics will give actually helps to drive these eras. So, for example, in where we are moving away from opioid use, we're having opioid sparing strategies. We'll make sure that we give opioid-free anesthetics and make sure that we give a block. This will allow our patient to mobilize quickly, heal quickly, as well as we're able to discharge this patient quickly. So we are the key drivers for ERAS strategies. Next slide. Yeah, in terms of collaborating with physicians, we take on a proactive role. So we coordinate with primary physicians to make sure that we optimize complex medical conditions. And also we make sure that as the patient is reaching the operating room door, they are well optimized for the proposed surgery. So the emphasis is that critical care coordination actually helps with the patient improving, as well as us managing and being on top of whatever pathology we are managing in the patient in the critical care unit. For our nursing staff, we usually our nurses are like vital partners in continuity, because whatever that we do, for example, like intraoperatively, and we want to see how we want to see the patient do well postoperatively. Our nurses are our partners in that there is continuity of care if we put them on board with whatever our plans are. So this actually involves, like, for them actually implementing all of our protocols and our plans even after we've left the bedside. So this is why our collaboration with these different other colleagues is actually quite important, because when we've left the bedside, they will make sure that all of what we've planned for will actually move, and this will actually lead to quicker recovery. Next slide. We also collaborate with pharmacists, mainly for medication safety, and in a situation, for example, where we have higher lead drugs, or a situation where a patient is on a number of different drugs, we collaborate with them and we have a discussion to find out what is actually safe for the patient, and make sure that we are actually providing the best care. And if there are any alternatives, these our colleagues actually recommend in terms of what is safest for the patient. And also in terms of rehabilitation coordination, one of the things is that for rehabilitation to actually work very well, we need to have a patient that's not in severe pain. We need to have a patient that is pain-free, and with us providing the analgesia plans, we actually help with good rehabilitation of the patient. This actually leads to early recovery, as well as, for example, like discharge in a situation where we have a patient that's in the ward and receiving rehabilitation. Next slide. So as continuous medical education, we are involved in training other providers in life-saving skills. As mentioned, we are more experienced with this basic life support, as well as advanced life support. And with this also, we need to keep organizing resuscitation workshops so that we allow retention of most of these skills, and also help with simulation-based training. Next slide. Yeah, so these are some of the life-saving skills training that anesthetists usually conduct and are part of. Heading this is a good thing, making sure that we have all of our team members knowledgeable about basic life support, advanced cardiac life support, as well as most of these our colleagues attending airway workshops so that we extend all of our expertise and make sure that people are more knowledgeable about how to handle airways and things like that. We are also involved in advanced trauma life support. We are experts in a number of things that most of our colleagues benefit from in terms of trauma. Next slide. Simulation training actually helps with retention of skill, and we are able to, for example, like teach concerning crisis resource management, where we emphasize the important pillars and takeaways, which include, for example, like recognizing when there's a problem and knowing when to call for help, making sure that resuscitation goes on well coordinated by choosing a team leader, emphasizing that we need a closed loop communication, as well as using resources wisely in a more effective manner. So if we're going to give roles, we need to make sure that we appropriately give roles, who is the best person to do this and that, such kind of things, and making sure that if we making sure and emphasizing that even after all of this, under crisis resource management, you are able to take a step back, have a global view and assessment of the whole situation, and just manage the situation adequately. So mock code drills are also a way that actually helps improve all of our outcomes, as well as how we manage stressful situations in our institutions. This also helps improve team communication, as we find ourselves and also the other specialties find themselves in a situation where you have a interdisciplinary you have a multidisciplinary, for example, like approach to a patient. For example, in the trauma suite, where you have a number of different teams, this actually helps with team communications through simulations. It's actually more effective. Next slide. So our mentorship role extends to training our more junior colleagues with the different skills that we have to make sure that we are able to manage our patients appropriately and safely. And we also help supervise nurse anesthetists, not just academically, but otherwise with skill from the pre-operative to the post-operative period, including extension into critical care. And we also help support rural healthcare workers, whether it's via consultation over the phone. This actually happens a lot, or as well as doing outreach programs where you actually help and build up these people. You visit rural healthcare settings to provide anesthesia services, and this actually helps with supporting these healthcare care workers. So in terms of training non-physician anesthetic providers, this is actually a good initiative that actually helps with building surgical services, because then all of the knowledge and the standardized practice that we have, we actually share all of this knowledge, and this actually helps to provide safe surgery. Standardizing protocols is one of the strategies that actually helps with providing safe surgery, in that, for example, if you compare tertiary institution like ours, UTH, where you have a standardized protocol, if that protocol can be implemented in a district hospital, that will actually reflect the kind of safety and standard that a patient in that district hospital will be under. So it provides more of like a safety net to help standardize all of the practice, which is actually good for not only for us practitioners, but also at the national level. Next slide. So as an anesthetist, looking at our involvement from the pre-operative point in caring for a patient to the post-op, we are in a situation where we can actually be advisors for our healthcare system, in that we more of have a macro view of how the patient is managed from pre to post-op. So we are in a situation where we can actually advocate and advise on how we can improve the surgical safety systems in our countries and in our institutions. We have WHO safety checklists, and we need to make sure that we continuously implement and make sure that all of this is done. It's not just a paper, but it's actually a system that has been proven to prevent catastrophic issues, especially in the operating theater. And looking at us trying to standardize our practice, we need to advocate for essential equipment that will help keep the patient safe and make sure that our surgery goes well and we have a patient that's doing well post-operatively. And part of this is making sure that we have the right equipment, we have the essential equipment, and we have equipment that is working very well. So we need to advocate for essential equipment, which is just part of safe practice for us. Next slide. In terms of contributing to national health policy, as I mentioned, we need to, because we have a macro view of how the health system works in terms of how the patient comes to the hospital, and post-surgery, we can help in making sure that we advocate for health policies that will actually benefit our patients, that will help improve safety and improve outcomes. We also need to make sure that we set anesthesia standards, which can be replicated, and not just in the tertiary, but also out of in the district hospitals, smaller hospitals, that will actually help with safe practice and making sure that whatever level of care is received in the tertiary institution can also be received in the district hospitals. In terms of workforce planning, we have to be realistic and look at in terms of what workforce is available to us and how we can utilize the workforce, as well as making sure that we are able to provide safe practice, and if there will be need for more training, we can actually advocate for that. Okay, next slide. Audits and morbidity reviews are usually not a way of pointing figures, but these are ways in which we tend to look at cases, as well as to make sure that whatever was done wrong, we can actually refine our practice and actually improve on current practice. So in situations where we continuously have audits, this will actually help with refining whatever protocols that we have or whatever practice that we have in improving and reducing morbidity and mortality. So this actually helps to make sure that we have some patient safety initiatives that are coming up and that will keep improving on in our health system. And whenever we have data, for example, we have audits on what current issues and in our system, for example, we find out we get to find out that okay, most of our patients are not adequately optimized for a certain procedure. We need to make sure that we audit that, and that will actually drive practice into improvement, where we say, okay, because of this data that we have, we need to make sure that we implement a strategy to make sure that our patients are well optimized for this certain proposed surgery, and make sure that we improve on that, and that will improve on outcomes. Next slide. This is talking about anesthesia out of the operating room, and this is like one of the cases that actually happened in Kenya. And the emphasis is that there's no minor anesthetic. Yeah, so complications of non-operating room anesthesia actually come from 25% coming from imaging, as well as the other 25% coming from cardiological procedures. So the emphasis has been that there is no minor anesthetic. Every anesthetic has to be, whether it's minor, whether it's in the endoscopy or imaging, it has to be treated as a major anesthetic, and all preparations and availability of all, for example, airway, oxygen, equipment, suctioning has to be available like you're carrying out a major anesthetic in theater. So the emphasis is that the conditions that are in the operating room should also be the conditions that are out of the operating room for any sedation that you are carrying out. Next slide. And with multiple articles that have actually been shown for cases outside the operating room, the majority of complications are actually attributed to inadequate oxygenation and oversedation, which, for example, in the endoscopy, where you have a patient who has received sedation, but the goal was to get to moderate or deep sedation, and ends up leading to general anesthetic, of course, which we know sedation is a continuum with general anesthetic. So the emphasis has been that we need to make sure that those places are safe, they have all of the equipment, and you have the right team with you to make sure that in case of an emergency, you can be assisted, and you can make sure that you can intervene and to prevent these morbidities and mortalities. Next slide. So these are some guidelines for non-operating room anesthesia. Just a quick run through that every place should make sure that there's enough oxygen, and not only raw oxygen, but also reliable backup oxygen supply. You need to make sure that there's enough, there's a reliable suction as well as different suction catheters. As we know, mostly, for example, like in the endoscopy, it's not unusual to this is a place where the patients are at high risk of aspiration. We need to make sure that we have self-inflating bags and resuscitators that are able to deliver more than 90% of oxygen. So all of these are actually provisions that we actually need to make sure that we have in place as we are conducting any out of the operating room anesthesia. So we need to make sure that we have sufficient space to accommodate the necessary equipment that we need and the personnel. And we also need to make sure that we have all of our emergency drugs, our emergency cart, defibrillator should be available. We should have a trained anesthesiologist administering this sedation as well as trained support staff. As we know that if you don't have even a trained anesthesiologist without a good support staff or assistant will not be able to do well in a situation of crisis. So we need to make sure that we have trained staff to assist. And we also need to make sure that, as we know, we also need to make sure that we have a good recovery area. So a post-anesthesia care unit, because we know at the end of a procedure is not the end of patient recovery. We need to make sure that our patient is well recovered. There is trained staff to actually monitor the patient and staff that are able to recognize challenges in the post-anesthesia care unit, as well as help to resuscitate if there will be need. Next slide. So these are some of the monitoring and equipment that's actually important and necessary for us to conduct anesthesia out of the operating room. And these are equipment that it's actually a non-negotiable for you not to have them. These are supposed to be available. You need to make sure that all of our places where we are conducting any kind of anesthetic, we have oxygen and backup, we have suctioning should be available, we have visual access, we have an anesthetic machine with oxygen delivery, all of the suction catheters that we need. Should we need to intubate this patient, we have all of our intubation equipment available, intravenous pumps, should we need continuous sedation, and IV fluid administration, as well as our monitors, including capnography, which is quite important and a necessity in these situations. And we need to make sure that we are able to have transport capability for oxygen, delivery, oxygen tanks, as well as portable monitors if there will be need. Next slide. So this is an equipment checklist for NORA. We use the acronym SOAP-ME. It's a safety net for us anesthetists, which this is something that you can actually look up and make sure that we have all of these equipments before carrying out any kind of anesthetic away from the operating room. We make sure that we have suctioning, which should be of the appropriate size. We have the suction catheters. We make sure that we have reliable oxygen with a functioning flow meter, as well as backup oxygen. And we need to make sure that we have all of our airway adjuncts should we have any challenges with our airway. We need to also make sure that we have our emergency drugs, reversals for example, like naloxone, if we're going to administer any opioid during the sedation, as well as reversals for benzodiazepines. We need to make sure that we have got good working monitors. All of the standard monitoring should be available and should be working very well. And we need to have good working equipment with our defibrillator, with paddles. We need to make sure that we have gas scavenging, adequate lighting, as well as everything that we actually need to help manage patients who are coming in for out of the operating room anesthetics. So this is more. This actually mimics what everything that would have in the operating room. So this is more like having everything available in, for example, in the endoscopy suite. The next slide. So in terms of future recommendations, for anesthesia, we have actually expanded our perioperative medical services. We need to make sure that we apply ourselves in all of these areas. We strengthen ICU training, making sure that all of our colleagues in the ICU are mentored, and we make sure that we increase rural outreach programs to not only provide anesthesia services, but also to train our people in the district hospital. We also need to make sure that we promote research in anesthesia, not just relying on international research, but also have our own local research champions, as this will actually help with improving care. And also adoption of telemedicine, where we are able to actually, for example, like have a preoperative, more like a preoperative assessment in a patient who may be far out in the district, and we can be able to give advice to our colleagues, for example, the non-physician anesthetists who are actually taking care of the patient, and come up with ways in which we can, for example, optimize the patient prior to them receiving an anesthetic and surgery. We also need to look at the future of anesthesia with AI. So we actually find ourselves, for example, like having like AI algorithms that can actually analyze arterial waveforms to predict hemodynamic instability. For example, like severe hypotension minutes before it actually happens. And this will actually help to help us to actually intervene preemptively. And also the future of also chronic pain medication. We are moving away from systemic opioids towards procedures like ultrasound guided regional blocks, radiofrequency ablation, and neuromodulation. So this is something that we are actually, this is actually the future and the recommendations for our anesthesia practice. Next slide. So in conclusion, we've seen that as a skilled anesthesiologist, we not only need appropriate equipment and drugs, but we also need to make sure that we have available staffing, skilled staff around us. And as anesthesiologists, we play a vital role beyond the operating room. We find ourselves in trauma, critical care, HTU. We also provide pain management services for acute and chronic pain beyond the operating room. So we are contributors in all of these areas. Our expertise extends beyond the operating room. And we are also essential educators and system leaders. So our healthcare system needs us to continuously give input. This will actually drive patient safety up and help improve outcomes. We also need to make sure that as anesthesiologists, we make sure that we build a system in a way that we have adequate backup facilities in the system. We can't do this alone, and we need help from the ministries as well as a good functioning system to actually thrive and continue providing our services. Thank you so much. Next slide. Okay, thank you. Those are our references. So please ask your questions using the Q&A function at the bottom of the screen. Dr. Ndawa, thank you so much. I think maybe you can take over and guide.
Thank you so much, Dr. Katongo Mumba, for that very wonderful and quite elaborative presentation. You've covered quite a number of issues relating to the roles of the anesthetist in the healthcare system, adding to the literature and information that Dr. Abdullahi had shared earlier. So thank you so much, gentlemen, for the very wonderful presentation. So at this point, I think we'll spend the next 10 minutes just discussing this topic, inviting comments from colleagues on the platform, as well as from our panelists and the presenters. So just before I open up for questions or contribution, let me just quickly recognize some of the senior colleagues that have joined this discussion. We are grateful for your presence. So we have Professor Dati from Nigeria. I think we'll be glad to get some comments from him. We have Dr. Shweika from Kenya, Dr. Hope Piri, one of the senior anesthetists from the military institution in Zambia. We also have Dr. Hajara from Nigeria and Dr. Anthony Kalufuelu from Nigeria as well. To mention a few, we are grateful for your time to join this discussion. So allow me to open it up. Please, if you have any questions or contribution, please feel free to raise your hand. And if we don't recognize that immediately, please just unmute your microphone and go ahead and make a contribution.
Okay.
While we... All right.
Okay.
Thank you so much, Prof. You can go ahead. Thank you.
Okay, because I will soon be leaving. Thank you very much for the wonderful webinar. It comes at a very good time. I just want to say that, well, anyway, I did not listen to all the lecture where I was telling you, I wanted to also listen to the WFSA webinar. So it just ended like 10 minutes ago. So, but I want to say that the role of anesthetist outside the operating room receives less attention, even during our training. Now, the interest now has been renewed because of the unfortunate event that happened in Lagos recently. I'm sure it's gone viral everywhere. They're on it. But that's just to underscore the importance of anesthetic services outside the operating room. So I just want to say that it is good. I think from now on, we should give it more attention. And I'm glad that webinars There are about 2, 3, 4 webinars that occurred in different ways to underscore how important and how vigilant we should be when giving our services outside the operating room. People are now aware, more educated, and we need to be very vigilant. Thank you very much.
Thank you so much, Prof. We are forever grateful for your participation and the contribution that you make to these webinars. We are grateful. Yeah, so I think, like has been emphasized, the modern anesthetist can actually go as far and as high as they want within the medical or the health care system. And so we can find ourselves anywhere with the roles that have been presented in this discussion. Just want to check once again if there are any hands, or please feel free to unmute and go ahead and make a contribution if we can't immediately recognize your hand. So please feel free to interrupt. So while that is happening, I would like to invite Dr. Papicho just to make any additional comments to the presentation.
Thank you very much, Dr. Ndaba. Am I audible?
Yes, please.
Oh, thank you. I'm still Anthony is willing to say something. Anthony, do you have a way to say you want to make some comments? Anthony, that's fine. Is he still there or is gone? Okay. It seems like we lost Mr. Anthony. My few comments is that the role of anesthetist we've seen goes beyond the hospital, goes as far as in the health system, whereby we play a role in training our colleagues in the management of emergencies. We go into the clinic as it was presented. We go out of the main hospital. We follow the critical patients where they come from so that we go build capacity as far as in the clinics where they first receive the patient so they are able to treat those patients. Already that is a role of anesthesia out of operating. The only challenge that we have is that the number of qualified anesthetists across the continent, it's a challenge. We are very few, and this does not allow us to play fully our role. The few opportunities that we have to interact with our colleagues, let it be a teaching opportunity whereby we share our knowledge, we share our experience, so that whenever we are present or not, they are capable of identifying a critical ill patient and do something for them. We also acknowledge that in the role of anesthesia out of theater, there are roles that can exactly be played by anesthetists and roles that can be played by any other physician or clinician. What belongs to anesthetists will belong to anesthetists, and what can be played by other physicians can be played as long as they understand the principle behind the simple techniques that are going to play to save a patient. This covers everyone, all clinical anesthetic providers, starting from the nurse providers, from the clinical anesthetic providers, from the physician providers. We all have a big responsibility to play outside theater. Does not exclude everyone. So let's recognize our big role that we play in the hospitals so that we take good care of our dear clients that come to seek treatment. Okay. that I would like to make, unless if there's any question, and then I can come with some few answers as well.
Yeah, thank you so much, Dr. Papicho, for summarizing everything very well. Uh, um, we are grateful for that additional piece. As we wind up, let me just pick a comment from the chat box. But in case there's anyone with a critical contribution, as we wind up, please feel free to unmute and proceed. So in the chat box, we have a comment from Adan Hussein, who says anesthesia is the most important aspect in the surgical team. So we request inter-country sponsorship programs like refresher courses, blocks, pediatric anesthesia, multimodal analgesia, obstetric anesthesia, etc., etc. So I think this is well noted. It's part of capacity building. This is a direction to take. Yeah, so just to review another comment from Rachel Mbweza, who says, can you explain the definition of sedation? You define it as a continuum of general anesthesia. Can you explain the definition of sedation as a continuum of anesthesia? I think I'll give this to Dr. Katongo Mumba. I think he's trying to find out if you can explain sedation as a continuum of general anesthesia. Is that right? As we wind up.
Hello, yes. Yeah, so I think the point that I was trying to put across was that, for example, you are in, your goal is to sedate a patient, and you are planned for maybe minimal sedation. But what tends to happen is that these patients who, for example, you've planned for minimal sedation, sometimes can tend to slip into moderate sedation, as well as for patients where you need moderate sedation, conscious sedation, but that actually leads to deep sedation. So the point that I was trying to put across is that if you're going to conduct any kind of sedation, you need to be in a situation where you are ready for a general anesthetic. For example, you've planned for a deep sedation that can easily slip into a general anesthetic. Because we have minimal sedation, we have moderate sedation, we have deep sedation. All of these have got different characteristics in how our patient will respond to us and things like that. So the point that I was just trying to put across is that we need to make sure that we are aware that any kind of sedation can actually slip into general anesthetic, and they'll need support like airway, respiratory, as well as cardiovascular support. Thank you.
Yeah, thank you so much. I think for that response. I hope it suffices Rachel's question. Yeah, so I'll now allow just one from David Muir. I think he's expressed some comments or concern regarding our nurse anesthetists.
Hello, I hope you can hear me. I can't see my screen at the moment. But I'm just curious if anybody is aware of any sources of information about nurse anaesthetists in Africa. I'm interested in how the team operates as a whole, and I can't seem to find any information.
Dr. Gamba, maybe David can give us more information about himself, where he operates, and then why he trained as an anesthetist, because few knowledge that we know is that a good number of them in different countries, they are well recognized, and then they are practicing, they are even given responsibilities to work alone for different cases. So maybe can bring more information on the question that put on the table.
I'm really sorry, but unfortunately, I'm not getting a good signal.
Yeah. Hello, David.
I can hear you now.
This is Dati.
Oh, Dati.
Yeah, I
Hey,
was
you busy
trying
man.
actually to, I read your comments there, and I was trying to share, ask you, offer to give you some information later.
Oh, thank you.
Where we have, all I can say now is that from my experience, all over Nigeria, it's still happening. Most facilities, the services were provided by nurse anesthetists. And when residency takes over, then they're still there, but they are not, the residency program is followed, particularly in the teaching and specialist hospitals.
Right.
But now there is also a resurgence of training in nurse anesthesia program all over the country. I think there is population explosion. There are many facilities, and there is still a lack of access to surgery and anesthesia services. So it is there. There is a lecture I delivered to the Stanford University, I think, trainees last year. I'll look at it and share with you. Maybe there's some information, but I'll also give you what we have as at 2022, the figures that we have in Nigeria, non-physician anesthetists. This is referring to the nurse anesthetists. Thank you.
I appreciate it, Dr. Dati, but you're a busy man, and I'll look myself if you run out of time.
Great. Yeah.
Thank you very much.
Thank you. Yeah. Thank you.
Yeah. Hello, can I talk? This is Dr. Abdullahi Mustafa.
Yes, please.
Okay. I want to talk tangentially to what Prof. Dati said. Prof. Dati is my teacher, one of my mentors that put me through. So about the nurse anesthetists, it's not that their contribution is not being recognized. It's being recognized because they, even in the teaching hospital as at now, they are working, though the burden of work has reduced. But when you go to the peripheral hospitals, almost everywhere there are nurse anesthetists that are working for now in Nigeria. So they are relevant, and their role cannot be overemphasized. Thank you very much.
Thank you for that. That's really good to know.
Well, thank you. Thank you so much for bringing that up, David. We are grateful also for the responses that have been provided. Looking at time now, I would like to just thank everyone that attended this very important discussion, and more so to our two presenters for taking leadership in this discussion.
Dr. Ndaba, the moderator, please.
Yes.
Before you close up, I'm requesting that you allow Dr. Karima on the call to make a comment. She can make a big comment on the EC. It's one of the that we are promoting.
Okay.
Which is one of the role of anesthesia out of operating theater. I'm not sure if she's still around. Karima.
Okay. Dr. Karima, please proceed to make your contribution.
Hi, can you hear me?
Yes, thank you.
Thank you, Ndaba, and everyone for this wonderful webinar. My comment was just on our role beyond. I know that the webinar has been on the role of anesthetists outside the operating room, and I was so glad to see Dati and the rest who are also experts, and Dr. David Muir, who are experts also in ECC, also commenting. Mine was I just to say that we have the role of ensuring that the good work we are doing in ICUs, in theaters, in the wards, in everywhere else in the emergency rooms, in radiology units, outside, even in the field, continues beyond that area by ensuring that whatever is done in the wards is provided adequately. I heard the talks talking about provision of ensuring that the nurses or the junior doctors in the wards is supporting them to deliver the care that has been prescribed in our prescription that we give them to on the things that they're supposed to be doing, but we see that a lot of that is missing in the wards. So I think our role is also to make sure that we support the needs of these younger colleagues or our nurses who are in the wards to ensure that they have the resources that they need to provide the care that we would like them to provide. They have the resources in terms of equipment, guidelines, job aids, and the like that they would be able to use while in the wards to continue the care that we have done very well in providing in the areas that we are present in, because we cannot be everywhere all the time. I didn't want to talk a lot, but I have shared the recent publication that that was published in the Appetite Anesthesia on this, and everyone can read it. I wanted to put the link, but somehow I'm using my phone and I wasn't able to do that. But there is an article that we wrote on this very topic, the role of an anesthesiologist outside the operating room using the ECC lens. I think it would be a nice read for everyone just to get more information on this. And anytime maybe we can discuss this further in more details. There's a lot of experts within anesthesia who have been keen on ECC, and we can discuss this even in more details at a later webinar. Thanks. I think I've talked a lot.
Yeah, thank you so much, Dr. Karima, for sharing those insights. I also like your role that you're playing in the EECC. It's been helpful quite a lot. So thank you so much. Unless there's anybody else, Dr. Papicho, please help me. That I need to just quickly recognize before we close.
I'll be best if I miss anyone else. Thank you very much, Dr. Ndaba, for the wonderful leader.
Yeah, no, thank you so much. I also recognize quickly Dr. Leticia. Your views that you've posted, I think, will be taken into consideration. Thank you so much for the discussion. So at this point, I would like to invite Magdalena Mwalimo to help us close the webinar.
Thank you so much to our dear panelists, and also thank you so much our attendees for holding up. This has been our longest webinar. It has been very interactive. For more information, please reach out to our website, that is gradienthealth.org. Just click on it. You will find also our equipment, and for those of us who have our equipment, do not hesitate to reach out to us. We always offer all the assistance that you need. for service, for technical assistance, also for training on the usage of our machines. Thank you so much, and looking forward to more webinars. And yeah, thank you and bye.
Thank you. Bye-bye.
Thank you. Bye bye.